Hi, everybody. Hope you're all well. I got an interesting case that I came across that was sent to me by another doctor in our district. So I was just hoping to show it to you guys. So this was the X-ray that was sent through of a young gentleman who had presented to them with a few days of constipation, obstipation, as well as now abdominal pain. And he was struggling to eat anything, vomiting everything out. Now, for most of you, this may seem like a relatively simple diagnosis, and it is a relatively simple diagnosis. The doctor, on the other hand, at the local hospital was just a bit worried as to whether it met certain criteria or not. So the first thing that we notice in this X-ray, of course, you can see the gastric bubble, but we can see the dilated loops of bowel that are over here. So, and it's a lovely X-ray because it's actually, quite concentric and things like that. And these that we see here, these lines that go across, these are the valvulae conniventes. I hope I'm pronouncing that right. And this is quite typical of small bowel obstruction. So you get these dilated bowel loops along with air fluid levels. Now, they say you need to have at least 3, but I must be honest, it really does depend on the symptoms that the patient is presenting with as well. So, if it's a patient with a distended, guarded abdomen, and they may not have rebound tenderness, but they could have guarding sometime, depending on the amount of distension. Inability to pass flatus, inability to pass stools. There's so many reasons why it could happen, but very often with small bowel, and depending on where the obstruction is, vomiting can be an early sign. Sometimes it can be a late sign, and generally the more feculent the vomit is, the lower down the obstruction is. Now, this one looks more like a mid-bowel. And once you get to large bowel, of course, then vomiting can be a very late sign. And instead of seeing the conniventes here, you see haustra, which are very different, and I'll hopefully look at that sometime in another X-ray. Having discussed the patient with him, and let's just put this here just so that you guys can see it quite easily. So here we can see all of the air fluid levels. There's quite a few, so the patient now standing upright, we can see that, these are all air fluid levels sitting over here. So remember, nature abhors a straight line. So anytime you see a straight line on an X-ray, it means that something is going wrong, So this is one of those cases, So he's got quite a few dilated loops of bowel. He's got all the classic symptoms. The other things that you need to look out for now, of course, are perforation. And perforation will very often lead to sepsis. You may get air under the diaphragm. It just depends on how big the perforation is, but you'll generally get air under the diaphragm. If you lay the patient in a lateral decubitus on this side, you may see air over here on either side of the abdomen as well, and of course you go on your symptoms. So this patient was transferred to us. My understanding is that, he had a previous laparotomy for a knife injury, so he had developed adhesions, and the bowel had just quite simply twisted around. So that's another common reason for patients to have this. And it's any type of abdominal surgery, even laparoscopic surgery, there's a possibility of adhesive bands. Patient, then of course you've got to look at tumor as well, especially in a virgin abdomen that's never been under laparotomy. There's quite a few things that need to be looked at. And so that's basically what we look at in these X-rays. So the other thing that I wanted to show you is that if you are lucky enough to have the opportunity to have an ultrasound in your department, which we used to, unfortunately we don't anymore, but when we did, we would also ultrasound these patients. And these are the, let me just clear out all of those drawings, sorry about that. So let's just have a look at these as well. So here we have the ultrasounds of a patient with a small bowel obstruction. So here we can see, again, the valvulae conniventes quite easily. It's this foliated structure that's over here. Now, in this particular one, what I wanted to point out was just the to and fro motion of the stool. Because it's got nowhere to go, it tends to be quite liquid, and then it tends to pass backwards and forwards, So you'll see this to and fro motion that's happening. And you might see edematous bowel wall, as we can see here. So this is called the tanga sign for the simple reason that it looks like the underwear that's worn called a tanga. But even in this one here, you can see the dilation of the bowel wall. You can see the to and fro movement of the stools as well. So these are just two signs that you can look at quickly on ultrasound, and you can more or less immediately tell you that this is a small bowel obstruction. And then, of course, if you followed our ultrasound series, you would, of course, look for, free fluid in the abdomen. The tanga sign can sometimes make that a bit difficult, because is this free fluid or is this just edema? And you're going to look in your left and right upper quadrant, suprapubic as well, and you need to look at that as well. So your management of these patients, the first thing you need to do is decompress. So you pass a nasogastric tube, which is not the most pleasant experience for the patient, but it needs to be done. I don't know if you guys can hear my son there in the background. He's busy having the time of his life. Because dad is busy on the computer, so he is enjoying that. And you would decompress. These patients very often are dehydrated because now you've got extracellular loss of fluid. There's quite a lot of fluid that gets passed into the bowel as well. And these patients are often dehydrated, very often septic if they've had any sort of perforation, because there's a large amount of feces that will now leak into the abdomen. So they're very prone to sepsis. They're prone to appendicitis, depending on where it is as well. So you get a lot of, possibilities of what could and could not be going on with these patients, and they really need to be looked after very carefully. They will, of course, be discussed with your surgeons, and then your surgeons will decide on what they want to do. So like at our surgical department, not something I always agree with, but they tend to have a very conservative approach in that they try and decompress as much as possible and see if it will resolve on its own with nasogastric tubes and things like that, and providing a lot of fluid to the patient. The use of gastrographin can be diagnostic and therapeutic. So the patient takes gastrographin in order to see what or where the obstruction may be, and very often gastrographin may relieve the obstruction. And then, of course, your patient may need an urgent laparotomy as well, depending on the symptoms as well. But really, if from the emergency department point of view, our main things are decompress as quickly as possible. Well, diagnose, of course. You do your basic bloods, including a septic workup. You need to decide if you're going to give empirical antibiotics based on how the patient presents. Try and get the patient's fluid status back up to normal. You are, of course, going to mark your differentials based on what you can see. So if it's a patient with a previous laparotomy of any kind, including seizures, appendicectomies, laparoscopic surgery, full-on laparotomies, your first thing, of course, is adhesive bands with twists and things like that. And unfortunately, the more laparotomies you have, the greater your chance of developing small bowel obstruction. And please don't discount seizures. They do have, it's not to say it happens often, but it can happen. And of course, in a virgin abdomen, you're going to look at other causes. So you'd look for, signs of tumor, para-aortic lymph nodes. You'd look for aortic aneurysms. You'd look for renal, even though it's retroperitoneal, but it can cause obstruction. You'd look for all of these things that could possibly tell you that there may be a reason for the obstruction. You get helminthic infections. And trust me, it's not a pleasant sight to go in and remove a huge ball of worms from the intestine, but if it has to be done, it has to be done. So there's a lot of things that can lead to it, So you can, of course, get constriction, damage, trauma. There's lots of things that can cause it, but that's a whole list to go through. So anyway, I hope you guys enjoyed. I hope you guys will remember this X-ray as well, just so that you know more or less what a small bowel obstruction looks like, and you'll be able to diagnose it and manage it a lot better. Okay, thanks a lot, hopefully we'll have another one soon. Keep well. Bye.